Hello, dear student. Today you have a new topic in gastroenterology and discuss about peptic ulcer disease, another stomach and duodenal ulcer. So, a peptic ulcer is defined as disruption of the mucosal integrity of the stomach and or duodenum, leading to a local defect of excavation due to active inflammation. Although burning epigastric pain exacerbated by fasting and improved with meals is a symptoms complex associated with peptic ulcer disease. It's now clear that more than 90% patients with this symptom complex don't have ulcer, and that the majority of patients with peptic ulcers may be asymptomatic. As an estimated 15,000 deaths per year occur a consequence of complicated peptic ulcer disease. And you may see anatomy of digestive system, esophagus, stomach, and colon, duodenum. And you may see how show ulcer in stomach and duodenum. So some information about anatomy. The stomach occupies a small area immediately distal to the esophagus, the cardia, the upper region, the fundus under the left diaphragm, the mid-region of body, and the atrium, which extend to the pylorus. The smooth muscles of the wall of the stomach has three layers: outer, longitudinal, inner circular, and innermost oblique layers. There are two sphincters, the gastroesophageal sphincter and the pyloric sphincter. The latter is largely made up of a thickening of the circular muscles layer and controls the exit of gastric contents into the duodenum. The duodenum has outer longitudinal and inner smooth muscles layers. It is C-shaped and the pancreas sits in the concavity. It terminates in the gastroduodenal flexure where it joins the ileum. The mucosal lining of the stomach can stretch in size with feeding. The great curvature of the indistended stomach has thick fold of roach. The mucosa of the upper 2/3 of the stomach contains parietal cells that secrete hydrochloric acid and chief cells that secrete pepsinogen. There is often a color change at the junction between the body and the atrium of the stomach that can be seen macroscopically and confirmed by measuring surface pH. The antral mucosa secretes bicarbonate and contained mucose-secreting cells and G cells, which secrete gastrin, stimulated acid production. There are two major forms of gastrin, G17 and G34, depending on the number of amino acid residues. G17 is a major form found in the atrium, somatostatin, and suppressant of acid secretion. It also produced by specialized antral cells, T cells. Mucose-secreting cells are present throughout the stomach and secrete mucose and bicarbonate. The mucose is made of glucoproteins called mucins. The mucosal barrier made up of the plasma membranes of mucosal cells, and the mucous layer protects the gastrin epithelium from damage by acid and, for example, alcohol, aspirin, non-steroid anti-inflammation drugs, and bile salts. Prostaglandin stimulates secretion of mucose, and their synthesis is inhibited by aspirin and non-steroid anti-inflammatory drugs, which inhibit cyclooxygenase. And the duodenal mucosa has really like the rest of the stomach bowel and also contains Brunner's gland that secrete alkaline mucus. This, along with the pancreatic and biliary secretion, helps to neutralize the acid secretion from the stomach when it reaches the duodenum. And etiology. Obtaining a medical history, especially of a peptic ulcer disease, Helicobacter pylori infection. Ingestion of non-steroidal anti-inflammatory drugs or smoking is essential in making the correct diagnosis. Gastric and duodenal ulcers usually can be differentiated based on history alone, although some finding may be suggested. And what is ulcer and what is erosion, and what different between ulcer and erosion? Ulcer is necrosis involving the entire thickness of the mucosa that extends through the muscularic mucosa into the submucosa or deeper. Ulcers are defined as breaks in the mucosal surface more than 5 mm in size, with depth to the submucosa, and erosion, necrosis involving only the superficial mucosa. And pathophysiology. The majority of gastric ulcers can be attributed to other Helicobacter pylori or non-steroid anti-inflammation drugs induced mucosal damage. Gastric acid output, basal and stimulated, tends to be normal or decreased in gastric ulcer patients. When gastric ulcers develop in the presence of minimal acid levels, impairment of mucosal defense factor may be present. Gastric ulcers have been classified based on their location. Type 1 occur in the gastric body and tend to be associated with low gastric acid production. Type 2 occur in the antrum, and gastric acid can vary from low to normal. Type 3 occur within 3 cm of the pylorus and are commonly accompanied by duodenum ulcer and normal or high gastric acid production. And type 4 are found in the cardiac and are associated with low gastric acid production. Gastric ulcers tend to occur late in life than duodenal lesions, with a peak incidence reported in the sixth decade. More than one-half of gastric ulcers occur in males and are less common than duodenal ulcers, perhaps due to the higher likelihood of gastric ulcers being silent and presented only after complication develops. In contrast to duodenum ulcers, gastric ulcers can represent a malignancy and should be biopsied upon discovery. Benign gastric ulcers are most often found distal to the junction between the atrium and the acid secretory mucosa. Benign gastric ulcers are quite rare in the gastric fundus and are histologically similar to duodenum ulcers. Benign Gastric ulcers associated with Helicobacter pylori are also associated with antral gastritis. In contrast, non-steroid anti-inflammation drugs related gastric ulcers are not accompanied by chronic active gastritis but may instead have evidence of a chemical gastropathy typified by or hyperplasia, edema of the lamina propria, and epithelial generation in the absence of Helicobacter pylori. Extension of smooth muscle fibers into the upper portion of the mucosa where they are not typically found may also occur. Gastric infection with the bacterium Helicobacter pylori accounts for the majority of peptic ulcer disease. The organism also play a role in the development of gastric mucosa-associated lymphoid tissue lymphoma, MALT, and gastric adenocarcinoma. Although the entire genome of Helicobacter pylori has been sequenced, it is still not clear how this organism, which resides in the stomach, causes ulceration in the duodenum. Helicobacter pylori eradication efforts may lead to decrease in gastric cancer in high-risk populations, particularly in individuals who have not developed chronic atrophic gastritis and gastric metaplasia. The prevalence of Helicobacter pylori varies throughout the world and depends largely on the raw standard of living in the region. In developing parts of the world, 80% of the population may be infected by the age of 20, whereas the prevalence in 50% is in industrialized countries. Bacterial factor. Helicobacter pylori is able to facilitate gastric residence, induce mucosal injury, and avoid host defense. Different strains of Helicobacter pylori produce different virulence factors, including gamma-glutamyl transpeptidase, Flagella. This virulence factor is conjunction with additional bacterial consciousness can cause mucosal damage, in part through the ability to target the host immune cells. In addition, Helicobacter pylori may directly inhibit parietal cell kali natri ATPase activity through a KEGA-dependent mechanism, leading in part to the low acid production observed after acute infection with organism. Urease, which allows the bacteria to reside in the acidic stomach, generate NH3, which can damage epithelium. The bacteria produce surface factors that are hemotoxic for neutrophils and monocytes, which in turn contribute to epithelial cell injury. Helicobacter pylori makes proteases and phospholipases that break down the glycoprotein lipid complex of the mucosal gel, thus reducing the efficacy of first line of mucosal defense. Helicobacter pylori expresses adhesins which facilitate attachment of the bacteria to gastric epithelial cells. And host factor. Studies in twins suggest that there may be genetic predisposition to acquire Helicobacter pylori. The inflammation response to Helicobacter pylori includes a requirement of neutrophils, lymphocytes, T and B, macrophages, and plasma cells. The pathogen leads to local injury by binding to class 2 histocompatibility complex molecules expressed on gastric epithelial cells, leading to cell death. And duodenal ulcer pathophysiology. The reason for Helicobacter pylori-mediated duodenal ulceration remains unclear. Additional mechanisms by which Helicobacter pylori may cause epithelial cell injury include activated neutrophil-mediated production of reactive oxygen or nitrogen species and enhanced epithelial cell turnover, and apoptosis related to interaction with T cells and interferon gamma. Finally, the human stomach is colonized by a host or commensal organism that may affect the likelihood of Helicobacter pylori infection and subsequent mucosal injury. Helicobacter pylori associated with duodenal ulceration may be more virulent. In addition, certain specific bacterial factors such as the duodenal ulcer promoting gene A may be associated with development of duodenal ulcer. Another potential contributing factor is the gastric metaplasia in the duodenum of duodenal ulcer patient, which may be due to high acid exposure, permits Helicobacter pylori to bind to it and produce local injury secondary to the host response. Another hypothesis is the Helicobacter pylori antral infection could lead to increased acid production, increased duodenal acid, and mucosal injury. Basal and stimulated hysterine release are increased in Helicobacter infected individuals, and somatostatin secreting T cells may be decreased. Helicobacter pylori infection might induce increased acid secretion through both direct and indirect action of Helicobacter pylori and pro-inflammatory cytokines on GD and parietal cells. The final effect of Helicobacter pylori of the digestive tract is variable and determined by microbial and host factors. And non-steroid anti-inflammation drugs, peptic ulcer disease pathophysiology. Non-steroid anti-inflammation drugs represent a group of the most commonly used medications in the world. Even 75 mg a day of aspirin may lead to serious ulceration. Those no dose of non-steroid anti-inflammation drugs is completely safe. Prostaglandins play a critical role in maintaining gastroduodenal mucosal integrity and repair. It therefore follows that interruption of prostaglandin synthesis can impair mucosal defense and repair, thus facilitating mucosal injury via a systemic mechanism. Injury to mucosa also occurs as a result of the topical encounter with non-steroid anti-inflammation drugs, leading to increased epithelial surface permeability. Aspirin and many non-steroid anti-inflammation drugs are weak acid that remain as a non-ionized lipophilic form when found within the acid environment of stomach. Under this condition, non-steroid anti-inflammation drugs migrate across lipid membranes of epithelial cells, leading to cell injury once trapped intracellularly in the ions form. Topical anti-inflammation drugs can also alter the surface mucosa lie permit back diffusion of pepsin, leading to further epithelial cells damage. Non-steroid anti-inflammation drugs can also lead to mucosal injury via production of additional pro-inflammatory mediators like TFT and leukotriene through simultaneous activation of the lipogenase pathway. And genetic factor unrelated to Helicobacter pylori and anti-inflammation drugs in acid peptic disease. What may be? Cigarette smoking, genetic predisposition. And signs and symptoms. Signs and symptoms of peptic ulcer disease may vary depending upon the location of the disease and age. Gastric and duodenal ulcers can be differentiated from the timing of their symptoms in relation to meals. Epigastric pain is the most common symptoms of both gastric and duodenal ulcer. It is characterized by a gnawing or burning sensation and occurs after meals, classically shortly after meals with gastric ulcer and 2-3 hours afterwards with duodenal ulcer. Duodenal ulcer pain often awakens the patient at night. Food or antacid relieve the pain of duodenal ulcer but provide minimal relief of gastric ulcer pain. Symptoms consistent with anemia may be present. Sudden onset of symptoms may indicate perforation, and non-steroid anti-inflammation drugs induce gastritis or ulcer may be silent, especially in elderly patients. And you may see clinical comparison of gastric ulcer and duodenal ulcer. And at the left, gastric ulcer, and on the right, duodenal. Gastric ulcer occur on the stomach. Duodenal ulcer occur in the duodenum. Gastric ulcer, epigastric pain 1-2 hours after eating, and duodenal ulcer pain 2-5 hours after eating. Gastric ulcer can cause hematemesis of melena. Duodenal ulcer can cause melena or hematochezia. Gastric ulcer, in gastric ulcer present heartburn, chest discomfort, and early satiety after are commonly seen. And for duodenal ulcer, heartburn, chest discomfort are less common, but may be seen. And gastric ulcer can cause gastric carcinoma. Duodenal ulcer pain may awaken patient during the night. And what is common for duodenum and gastric ulcer? Epigastric abdominal pain, bloating, abdominal fullness, nausea and vomiting, weight loss or weight gain, hematemesis, melena. And what is hematemesis? In the vomiting of blood, which may be obviously red or have an appearance similar to coffee grounds. And melena is a passage of black tarry stools. It has characteristic tarry color and offensive smell, and it is often difficult to flush away, which is due to the alteration and degradation of blood by intestinal enzymes. Hematochezia is a passage of fresh blood per annus, usually in with stools. Physical examination. Physical exam may reveal epigastric abdominal tenderness and signs of anemia. Epigastric tenderness is the most frequent finding in patients. In uncomplicated peptic ulcer disease, the clinical findings are few and non-specific and include the following: epigastric tenderness, right upper quadrant tenderness may suggest a biliary etiology, or less frequently peptic ulcer disease. Guaiac-positive stool resulting from acute blood loss, melena resulting from acute or subacute gastrointestinal bleeding, secession splash resulting from partial or complete gastric outlet obstruction. And warning. Symptoms or alarm symptoms that should prompt urgent referral include unintentional weight loss, progressive dysphagia, overt gastrointestinal bleeding, iron deficiency anemia, recurrent emesis, a family history of upper gastrointestinal malignancy. And differentiating between Helicobacter pylori and anti-inflammation in drugs-induced ulcer. Ulcer associated with Helicobacter pylori, more often in duodenum, often superficial, less severe gastrointestinal bleeding. Ulcer associated with anti-inflammation drugs, more often in stomach, often deep, more severe gastrointestinal bleeding, sometimes asymptomatic. Diagnostic evolution. The 2017 American College of Gastroenterology guidelines for the treatment of Helicobacter pylori infection includes the following recommendation for testing for Helicobacter pylori. All patients with active or past history of peptic ulcer disease, low-grade gastric mucosa-associated lymphoid tissue, lymphoma or history of endoscopic resection of early gastric cancer. Patient with dyspepsia who are undergoing upper endoscopy, patient on long-term low-dose aspirin, patient initiating a long-term therapy with non-steroidal anti-inflammatory agents, patient with unexplained iron deficiency anemia following standard workup, adults with idiopathic thrombocytopenic purpura. And these guidelines also recommended post-treatment testing to prove eradication of Helicobacter pylori infection with the use of urea breath test, fecal antigen test, or biopsy-based testing at least 4 weeks following completion of antimicrobial therapy and after proton pump inhibitor have been withheld for 1-2 weeks. Helicobacter pylori test is essential in all patients with peptic ulcer. Endoscopic or invasive tests for Helicobacter pylori include a rapid urease test, histopathology, and culture. Rapid urease tests are considered the endoscopic diagnostic test of choice. The presence of Helicobacter pylori in gastric mucosal biopsy specimens is detected by testing For the bacterial product ureas, fecal antigen testing identifies active Helicobacter pylori infection by detecting the presence of Helicobacter antigen in stools. This test is more accurate than antibody testing and is less expensive than urea breath test. Before the urease breath testing, patients should discontinue antibiotic and bismuth compounds for at least 4 weeks and proton pump inhibitors and sucralfate for at least 2 weeks. This medication can reduce the urease activity of Helicobacter pylori and can generate a false negative result. Histamine 2 receptor antagonists should be ideally discontinued 24 to 48 hours before the testing to avoid a false negative result. Use of antacids is permitted. Urea breath test detected active Helicobacter pylori infection by testing for the enzymatic activity of bacterial ureas. Helicobacter pylori produce an enzyme called urease, which breaks urea down into ammonia and carbon dioxide. In the presence of urea produced by Helicobacter pylori, labeled carbon dioxide is produced in the stomach, absorbed in the bloodstream, diffuse the lung, and exhaled. Endoscopy imaging. Endoscopy provides a more sensitive and specific approach for examining the upper gastrointestinal tract. In addition to permitting direct visualization of the mucosa, endoscopy facilitates photographic documentation of a mucosal defect and tissue biopsy to rule out malignancy of Helicobacter pylori. Endoscopic examination is particularly helpful in identifying lesion too small to detect by radiographic examination or evaluation of atypical gastroradiographic abnormality, or to determine if an ulcer is a source of blood loss. Endoscopic is required to document healing of gastric ulcer and to rule out gastric cancer. This usually is performed 6-8 weeks after the initial diagnosis of peptic ulcer disease. Documentation of Helicobacter pylori cure with a non-invasive test such as urea breath test or fecal antigen test is appropriate in patients with complicated ulcer. So, you may see endoscopy image for duodenal ulcer and for gastric ulcer. Barium X-ray imaging. Barium studies of the proximal gastrointestinal tract are rarely used as first test for documenting as ulcer. The sensitivity of all the single contrast barium used for detecting a duodenal ulcer is as high as 80%, with a double contrast study providing detection rates as high as 90%. Sensitivity for detection is decreased in small ulcer, less than half of centimeter, with presence of previous scarring or in postoperative patients. A duodenum ulcer appears as a well-demarcated crater, most often seen is a bulb. Helicobacter management recommendation. Stool antigen tests are appropriate where the prevalence of Helicobacter pylori infection in less than 30%. A positive Helicobacter stool antigen test is highly predictive of the presence of Helicobacter pylori infection. Helicobacter pylori disappears quite quickly from the stool after eradication, therefore positive results indicate persistent active infection. To avoid false negative results, patients should be off antibiotic for at least 4 weeks and off proton pump inhibitors and bismuth for at least 2 weeks. Histamine 2 receptor antagonist and acid preparation are allowed. And treatment. The guidelines indicate that selection of an Helicobacter pylori infection management regimen should take into account any previous antibiotic exposure. The Association of Gastroenterology also includes the following therapeutic strategies for first-line treatment. 14 days of bismuth quadruple therapy, bismuth, proton pump inhibitor, tetracycline, and nitramidazole. Particularly in those with previous macrolide exposure of a penicillin allergic. Recommended option 14 days of concomitant PPI, clarithromycin, amoxicillin, and nitramidazole. Strong recommendation. 14 days of clarithromycin, triple therapy, clarithromycin, PPI, and amoxicillin of metronidazole should be reserved for patients with no previous history of macrolide exposure who live in regions where clarithromycin resistant amount Helicobacter pylori isolates is known to be low. Conditional recommendation. Suggested option 7 days of sequential therapy with PPI and amoxicillin, followed by 7 days with clarithromycin and PPI and nitramidazole. Conditional recommendation. Suggested option 7 days of hybrid therapy with PPI and amoxicillin, followed by 7 days with PPI, amoxicillin, clarithromycin, and nitramidazole. Next, suggested option 14 days of levofloxacin triple therapy, levofloxacin, PPI, amoxicillin. Conditional recommendation and suggested option 7 days of fluoroquinolone sequential therapy, PPI and amoxicillin, followed by 7 days of PPI, fluoroquinolone, and nitramidazole. And you see approach to selecting antibiotics for patients with Helicobacter pylori. Okay. Key questions is a penicillin allergy and previous macrolide exposure for reason, and several variants for answers. No allergy, no macrolide exposure recommended treatment. Case with without allergy but with present macrolide exposure recommendations. Maybe allergy present and macrolides exposure absent recommendation, and when allergy and macrolides exposure present, recommended treatment. Next, drugs which you use, antacids. And what is mechanism of action? Promote gastric mucosal defense mechanism, secretion of mucous protective barrier against H.pylori, bicarbonate helps buffer acid properties of H.pylori. Prostaglandins prevent activation of proton pump, which result in decreased H.pylori production. And what is variant of antacids? Aluminum hydroxide and magnesium, calcium bicarbonate, magnesium hydroxide, and sodium bicarbonate and citric acid. And you may see brand name for every these active ingredients. Next group of anti-acid neutralizing inhibitor drugs, histamine 2 receptor antagonist. Four of these agents are presently available: cimetidine, ranitidine, famotidine, and nizatidine, and their structures share homology with histamine. And doses for cimetidine, 800 milligram, ranitidine 300 milligram, famotidine 40 milligram, and nizatidine 300 milligram. And what actions? The histamine receptor antagonists inhibit acid production by reversibly completing with histamine for binding to histamine 2 receptor on the basolateral membrane of parietal cells. Block histamine for stimulating the acid-secreting parietal cells of the stomach. And histamine antagonists, mainly basal, psychic nitrogenic gastric secretion is suppressed and thus stimulate H, gastrin, alcohol, food, and inhibited. Next drugs is PPI. Omeprazole, esomeprazole, lansoprazole, lansoprazole, and pantoprazole are substituted benzimidazole derivatives that covalently bind and irreversibility inhibit. Kali natrium ATPase inhibited gastric acid secretion. They are most potent acid inhibitor agents available. Omeprazole and lansoprazole are the PPIs that have been used to the longest time. Both are acid-level and administered as enteric-coated granules is a sustained-release capsule that dissolves within the small intestine at a pH of 6. Lansoprazole is available as orally disintegrated tablet that can be taken with or without water, an advantage for individuals who have significant dysphagia. Pantoprazole and rabeprazole are available as enteric-coated tablets. Lansoprazole is also available a parenteral formulation for intravenous use. And what about doses? Omeprazole 20 mg a day, lansoprazole 30 mg, pantoprazole 40 mg, lansoprazole 20 mg, esomeprazole from 20 to 40 mg. And next group of drugs, cytoprotective agents and bismuth-containing preparations. Colloidal bismuth subcitrate and bismuth subsalicylate are not what widely used preparation. Bismuth subsalicylate is a highly insoluble complex of trivalent bismuth and salicylate. The mechanism by which these agents induce ulcer healing is unclear. Adverse effects with short-term use include black stool, constipation, and thickening of the tongue. Long-term use with high doses, especially with the IVth CBS, may lead to neurotoxicity. Their compounds are commonly used as one of agents in an anti-Helicobacter pylori regimen. The mechanism of action of bismuth of gastrointestinal pathogens include Helicobacter pylori are complex and include inhibition of protein and cells wall synthetize, membrane function, and ATP synthetize. Adherence of Helicobacter pylori to surface epithelial cell is also impaired. And next, drugs, sucralfate. Sucralfate is a complex sucrose salt in which the hydroxyl groups have been substituted by aluminum hydroxide and sulfate. This compound is insoluble in water and becomes a viscous past within the stomach and duodenum, binding primarily to sites on active ulceration. Sucralfate may act by several mechanisms, serving as psychomechanical barrier, promoting atrophic action by binding growth factors such as AGF, enhancing prostaglandin synthesis, stimulated mucose and bicarbonate secretion, and enhancing mucosal defense and repair. Toxicity from the drugs is rare, the constipation being most common. Standard dose of sucralfate is 1 gram prostaglandin analogies. The mechanism by which these rapidly absorbed drugs provide its therapeutic effect is through enhancement of mucosal defense is repair, inhibit gastric acid secretion, inhibit cytoprotective activity, enhance local production of mucosal bicarbonate, promote local cell generation, help to maintain mucosal blood. And what is the name of these drugs? Prostaglandin analogies, misoprostol. Doses 200 microgram 4 times a day. And therapy of non-steroid anti-inflammation-related gastric or duodenal injury. Injurious agents should be stopped as the first step of the therapy of active anti-inflammation-induced ulcer. This is possible when treatment with one of the acid inhibitor agents, histamine blockers or PPI, is indicated. Cessation of anti-inflammation drugs is not always possible because of the patient's severe underlying disease. Only PPIs can lead heal gastroendorenal ulcer. independent of whether anti-inflammation drugs are discontinued. The widespread use of anti-inflammation drugs has created some concern due to the increasing likelihood of gastrointestinal side effects associated with this agent. The approach to primary prevention has included avoiding the agent using the lowest possible dose of the agent for the shortest period of time possible, using anti-inflammation drugs that are theoretically less injurious, using newer topical anti-inflammation drugs preparation, and or using concomitant medical therapy to prevent anti-inflammation drugs-induced injury. And primary prevention of anti-inflammation-induced ulceration can be accomplished by misoprostol or PPI. High-dose histamine blockers have also shown some promise in preventing endoscopically documentable ulcers, although PPI are superior. Gastric protection therapy is required in individuals taking COX-2 inhibitors, cyclooxygenase, and aspirin prophylaxis. And surgical therapy. Surgical intervention in peptic ulcer disease can be viewed as being as electing for treatment of medically refractory disease as or as urgent emergent for the treatment of ulcer-related complication. Refractory ulcers are an exceedingly rare occurrence. Surgery is more often required for treatment of an ulcer-related complication. Hemorrhage is the most common ulcer-related complication, occurring in 15–25% of patients. Bleeding may occur in many age groups, but it most often seen in older patients. The majority of patients start bleeding spontaneously. Pre-peritoneal perforation occurs in 2–3% of duodenal ulcer, with anti-inflammation drugs-induced gastric ulcer perforation occurring more commonly. Pyloric channel ulcer or duodenal ulcers can lead to gastric outlet obstruction in 2–3% of patients. Surgical treatment was originally designed to decrease gastric acid secretion. Operations most commonly performed include vagotomy and drainage, highly selective vagotomy, and vagotomy with enterectomy. Two principal types of the reanastomosis are used after enterectomy: gastroduodenostomy bilirubin 1 and gastroyeyunostomy bilirubin 2. And what is complication for peptic ulcer disease? Upper gastrointestinal bleeding, gastric outlet obstruction, perforation, penetration, gastric cancer. And ulcer-related condition have name Zollinger-Ellison syndrome. And severe peptic ulcer, diathesis secondary to gastric acid hypersecretion due to unregulated gastrin release from non-B cells, often well-differentiated neuroendocrine tumor. Gastrinoma defines the components of Zollinger-Ellison syndrome. Initially, Zollinger-Ellison syndrome was typified by aggressive and refractory ulceration in which total gastrectomy provides the only change for exhausted survival. Today, it can be cured to surgical resection in up to 40% of patients. And what is clinical manifestation? Gastric acid hypersecretion is responsible for the signs and symptoms of certain patients with this syndrome. Peptic ulcer is the most common clinical manifestation, occur in more than 90% of gastrinoma patients. Initial presentation ulcer location may be indistinguishable from common peptic ulcer disease. Clinical situations that should be create suspicion of gastrinoma are ulcers in unusual location, ulcer refractory to standard medical therapy, ulcer recurrence after acid-reducing therapy, ulcer presented with frank complication, bleeding, obstruction, perforation. Ulcers in the absence of Helicobacter pylori of anti-inflammation drugs ingestion. Symptoms of esophageal origin are present in up to a third of patients with Zollinger-Ellison syndrome, with a spectrum ranging from mild esophagitis to frank ulceration with stricture and Barrett's mucosa. Diarrhea, the next most common clinical manifestation, is found in up to 15% of patients, although diarrhea occurs concomitantly with acid peptic disease. It may also occur independent of an ulcer. Etiology of diarrhea is multifactorial result from marked volume overload to the small bowel. Pancreatic enzyme inactivated by acid and damage of intestinal epithelial surface by acid. The epithelial damage can lead to a mild degree of maldigestion and malabsorption of nutrient. The diarrhea may also have a secretory component due to the direct stimulatory effect of gastrin or enterocytes or the co-secretion of additional hormones from the tumor, such as vasoactive intestinal peptide. And interesting questions for you about pregnant woman. A pregnant woman first trimester comes to you with peptic ulcer disease. Which drug will you prescribe for her? Antacids or sucralfate. And why? Histamine antagonists cross placenta and are also secreted in breast milk. Safety of proton pump inhibitors not established in pregnancy. Misoprostol caused abortion. So, dear student, thank you for your attention. If you have questions, please welcome to comments of this video, and please write your name, surname, and number of group under the video. So, see you again and goodbye.